Cerebrovascular accident or stroke and brain injury are two of the most common neurological problems faced by therapists and will be covered in this lesson. Each of them could be a semester course, but I will try to hit the major points for both in this week.
Listed here are the major questions you should be able to answer after viewing this presentation. These questions will again be displayed at the end of the unit for your review. Pause the presentation in order to take time to carefully read and understand these questions.
A CVA or stroke usually occurs very suddenly and often confuses those near the individual at the time it occurs. These 6 important signs of a stroke are referred to as BFAST, using the first letter of each symptom. A stroke is caused by reduced flow of blood or vascularization to the brain. A clot may block an artery, which causes lack of blood flow, and therefore death of tissue, either by slowly forming and blocking off a vessel, and is referred to as a thrombus. Or a piece of a forming clot may break free and travel through the cerebral vessels until it gets to a small vessel which it blocks, and is called an embolus. The third cause of a stroke is a rupture to a blood vessel due to a weakened vessel wall, and is called a hemorrhage or aneurysm. The major blood vessels serving the brain are shown here, with the vessels alone on the left, and as they are located in the brain to the right. The 3 major cerebral vessels are the anterior, middle, and posterior cerebral arteries. The anterior and middle cerebral arteries are divisions of the internal carotid artery in the neck, while the posterior cerebral artery is formed by the vertebral arteries traveling through the foramina, or holes, in the transverse processes of the cervical vertebrae. The anterior cerebral artery serves the area of the cerebrum mainly responsible for the trunk and lower extremities. The middle cerebral artery serves the area of the cerebrum mainly responsible for the neck and upper extremities. And the posterior cerebral artery serves the posterior cerebrum mainly responsible for vision. The most common stroke occurs due to a thrombus of the internal carotid artery, and therefore affects movement and sensations on the opposite side of the body in the neck, trunk, and extremities. The 2 cerebral hemispheres have somewhat differing cognitive and sensory-motor functions as shown in this graphic. Of course, the most important difference is that a stroke in the left hemisphere may create sensory-motor problems in the right side of the body, while a stroke in the right hemisphere may create sensory-motor problems mainly in the left side of the body. Of major consideration is also the fact that the right hemisphere is particularly responsible for language and communication, which could cause a problem with speaking, writing, and listening. But the right hemisphere is strong in judgment and nonverbal thought, and the person is well aware of their problems and safety concerns. Though the person with a left hemisphere stroke may be able to speak and understand language, they are often impulsive and unsafe due to not understanding their problems, and may be very unsafe if left alone. Eye function in visual fields is rather interesting as to how the brain perceives vision. The right occipital lobe does not get all of its input from the right eye. Look at this diagram and see that the right occipital lobe receives input from the right side of the right eye, which represents half of the left field of vision. The right occipital lobe also receives input from the right side of the left eye, which represents the other half of the left field of vision. Therefore, when looking straight ahead, the right occipital lobe is responsible to receive vision to the left side of midline, and the left occipital lobe is responsible to receive vision to the right side of midline. If a person has a stroke affecting the right cerebral hemisphere, they may lose vision on the left side, which is called hemianopsia. If they are looking straight ahead, they will not see things to the left side. If you give them a piece of paper to write on, they may only write on the right side of the paper. My most memorable moment with a left stroke patient occurred when she was eating lunch and asked me to get her some more food as she was still hungry. When I looked at her plate, she had only eaten the food on the left side. So I turned the plate around, and she thanked me for refilling her plate. One of the most common evaluations used for stroke patients in the Western Hemisphere is called the Functional Independence Measure, which is shown on this slide. It includes 19 tasks which are evaluated using an 8-point scale shown to the right. You may also find the 6-level functional ambulation classification helpful in evaluating a stroke patient's ambulation skills. Of course, a common problem with stroke patients is increased tone in the areas of the body where sensory motor function is impaired. As outlined in the spasticity lesson, this is primarily due to suppressor areas being affected by the stroke. The 3 suppressor areas are the premotor cortex, the basal ganglia, and some of the cerebellar nuclei. If a stroke is large enough to include the premotor cortex and basal ganglia, then spasticity on the opposite side of the body may be very high and to some degree lifelong. However, if just the premotor area is involved, the increased tone will probably not be permanent, but will certainly require attention during the initial stages of treatment. In treating stroke patients, it is important to remember the basics of Rude's developmental sequence. For example, it is obviously not appropriate to begin ambulation training with a stroke patient who does not have sitting balance. Lastly, in regards to stroke, it's interesting that the first use of FES, or functional electrical stimulation, was used to assist with ankle dorsiflexion while ambulating. It is important during ambulation that following push-off with the forefoot, a person then dorsiflexes the ankle in order to lift the forefoot clear of the surface in the swing-through phase. However, one of the most commonly affected muscles after a stroke is lack of voluntary control of the tibialis anterior. Therefore, a pressure switch was placed in the heel of the shoe, which would cause stimulation of the anterior tibialis muscle whenever there was no pressure on the switch. Therefore, as the heel is lifted from the floor during ambulation, the muscle is stimulated to dorsiflex the ankle, and when the heel is again pressed to the floor, it causes the stimulation to stop and relaxes the anterior tibialis. Now, let's move on to look at brain injury. Certainly, stroke may be considered a brain injury as well. Other major causes of brain injury include meningitis, trauma, and tumors. One of the evaluation tools used to determine severe brain injuries is the Glasgow Coma Scale. It evaluates eye opening, verbal response, and motor response to determine severity. Using this scale, a total score of 8 or less indicates the person is in a coma. A common term in reporting level of traumatic brain injury is to refer to the amount of diffuse axonal injury, or DAI. Myelinated axons within the brain are damaged, and level of damage will determine overall level of injury and prognosis for recovery. Referring to the amount of DAI by grade can be helpful in understanding severity, with grade 1 the least and grade 3 the highest or worst level. One of the things that occurs with severe brain injury is that the brain begins to turn off unnecessary functions in order to maintain life, which tend to be the higher functions, and the person becomes less responsive with a lower Glasgow Coma score. As the brain begins to recover, it often requires good therapy to help the person reawaken the areas of the brain for higher functions. Therapists must be aware of the need to talk to the patient and explain what they are doing with the assumption the person is understanding, which is often the case. The need for gentle reassurance and presence of family and friends is often critical to the person's recovery. The level of increased tone is often a problem early on in severe brain injury cases and often gives a clue as to the level of the injury. In severe cases, a person may exhibit decorticate posturing with severe extension in the lower extremities and severe flexion in upper extremities. This decorticate posturing supports the level of injury as a separation of function of the brain's cortical region or cortex from the lower levels. An indicator of greater damage is decerebrate posturing with severe extension in all extremities, which indicates separation of the entire cerebral hemispheres from the lower level functions. There are many awakening approaches to encouraging the brain to resume normal function after entering a comatose state, which include the sense of smell and enjoyable emotions by family and friends visiting and interacting with the patient. Remember that the oldest part of the cerebral hemispheres is the limbic lobe, which is responsible for smell and emotions. Managing tone is one of the most common tasks for therapists in working with brain-injured individuals. Using maximal resistance to increase output from the Golgi tendon organ can be helpful in reducing tone, as can submaximal resistance to encourage stimulation of the 1A fibers in the antagonist to the spastic muscles. Both of these have been examined more closely in the lessons on muscle receptors and spasticity. Finally, brain injury affects the entire family, not just the patient, and family often ask what they can do to assist in the recovery and therapy process. It is important to include family in therapy as much as possible and give them good resources to learn more about how they can be helpful. One of the best resources can be found at www.nbia.ca.
As at the beginning of the presentation, listed here are the major questions you should be able to answer after viewing this presentation. Pause the presentation in order to take time to carefully read and understand these questions.